Proton lecture series monthly, and we have a series of experts who have given their experiences and provided expert opinion on various experiences they had related to uveitis. So today we have none other than Professor John Kempen. I don't think anyone who's practicing uveitis need any introduction, to Professor John Kempen, who is the Director of Epidemiology and Ophthalmology and Director of Global Surgery and Health at Massachusetts Schepens Eye Research Institute at Harvard Medical School. He has made several seminal contributions in the field of uveitis, particularly related to epidemiology of uveitis, and run many major clinical trials related to uveitis. He's been my mentor for past many years, and mentor for the entire Proton team. So that's something we are very extremely thankful to Professor Kempen for giving his time. He's been recently not recently, but for years plus, he's moved over the eye care programs. We like to welcome related to epidemiology of uveitis, which I sure all of you will agree it's quite varied. And let's hope Professor Kempen can educate us a little bit more about this complex disease and how do we pursue such a complicated topic. Thank you, Professor Kempen.
Okay. Can you see the slide?
Yes, Ken. Everything is good.
Okay. So I just got a new internet system and I hope it's going to work. It's been working perfectly, but it was breaking up a little while Rupesh was talking. So let me know if you're not hearing. I'm going to be talking about using epidemiological evidence to learn about ocular inflammation. First, talking about one of the issues that I think is misunderstood, and then giving several examples. So this is the sort of current approach to the Oxford levels of evidence, where there's sort of expert opinion, theories, and so on, preliminary data from case reports or case series, case control studies, cohort studies, and then randomized trials, and then filtering a lot of trials or other studies together into systematic reviews and meta-analyses. Can you hear me?
Yes.
Yes.
Okay, good. So I'd like to begin just by considering, is a clinical trial the best design for all important questions? So many prestigious journals tend to publish original data from clinical trials almost exclusively because it's supposed to be the best quality evidence. But I would argue that this approach may not be appropriate because clinical trials actually can only be used for a small subset of questions that we have in clinical management. So let's just consider a sort of amusing indication to think about this. So there have been a couple of publications we'll go through sort of, as a making fun of this issue. And so let's go through them. So the indication of using a parachute is to prevent harm. So it's a prevention intervention when jumping out of airplanes. The treatment itself is thought not to be harmful, but the clinical course without treatment is suspected of being harmful. And so the ideal time sequence of evaluation of a therapeutic or preventive treatment like this would be to have a hypothesis and then some supporting initial data, and then early phase trials, pivotal trials such as the FDA or EMEA might use to approve a treatment, and then possibly post-approval trials and evidence-based reviews and meta-analyses. So I wanted to look into this to see if I could find any preliminary data about the presumed benefits and possible safety of parachutes for gravitational challenge. And so I was actually able to find a video from MI6 that, in essence, we can watch and see the cohort study playing out in practice, because government entities like these, and such as the military, have a special interest in the use of parachutes. So let's go ahead and play the video, and I'm going to just narrate a bit. Can you still hear me?
Yes, we can hear you.
Good. So this is a retrospective cohort study. James Bond is here, and he's just saying that he would love to keep traveling with her, but she's saying that this will be the last time that he does. And then this man's going to take over here, and they're both going to jump out of the airplane, leaving him to fall. So he's not pleased with this. So the airplane's starting to go down there. So we have a bit of a tussle. In a movie, it can never be a good fight unless both kind of have a chance, and the hero always has to be threatened quite a bit. So, but he manages to send our first cohort member for his trip there. So there goes the first one of the active treatment patients. And then there goes the control patient. And then one more control patient. So IRB approval likely would be expedited for this because it's a retrospective study with no subject contact, as long as the data is stored and reported in a manner avoiding compromise of patient privacy rights. The woman in the presumably active parachute group is a dropout, and we have no information on her course. Bond has unmasked control treatment, and the other two have active parachute treatment. In terms of patient-reported outcomes, we can infer from the actions of the participants in the study that there's a much more favorable user experience with active treatment compared to unmasked control treatment, even though there's no formal evidence regarding the risks and benefits of the alternatives at this time. Masking would have been a better way to assess patient-reported outcomes, but would have been difficult to implement in this setting. So this one, unfortunately, is censored. Possibly, or we don't know his outcome. Possibly it could be informative censoring based on the strength of treatment preference he has. Now, as the follow-up goes on, we have some treatment crossovers. So there you can see Bond is crossing over in his treatment. The first person who was censored was a crossover as well. And then Jaws here is going to have a crossover too. So let's see what happens. Whoops, surprise. But fortunately, we can use our head. And there goes the implementation of the crossover treatment. So while there's nothing Jaws can do and he's irritated, oops, he pulled a little too hard and crosses over to no parachute treatment. Fortunately, there's a large big top tent there. So that's the end of the video. Now, it's difficult to decide if Jaws's treatment crossed over should be analyzed as assigned or as treated. In a randomized trial, once assigned, the subject should always be analyzed with their assigned treatment group to avoid introducing indications for treatment bias, a form of selection bias. In a cohort study like this, however, we usually use as treated analysis because we can't entirely control selection bias. There are certain inverse probability weighting techniques that I've dabbled in which you can construct treatment groups that are virtually balanced as if they had the same baseline characteristics, but it works with a big sample size and other complexities. Overcoming selection bias and balancing unknown confounders are the two advantages of the randomized trial methodology. We find out later that Bond and Jaws both survived, but we don't know the outcome of the other two. In conclusion, then, based on hypothetical considerations and the strong preferences of the subjects, parachute for gravitational challenge seems worth further study, even though no primary outcomes were observed in either group in this preliminary look. We also observed that pulling the parachute trigger too hard could potentially result in incomplete active treatment, and this could be a possibility with treatment use. We can say that the Drax company ought to modify their design in order to make sure the parachute works, even for beefy users. Okay, so let's resume the talks. So I'm going to just skip over this, but I used quite a few key terminology items that we would use in clinical trials here. We'll talk more about it as we go. So if we were continuing our clinical trial paradigm, then we would do a search and see if anything was found. And so there indeed weren't any other clinical trials found, at least back in 2017, but there was a systematic review and meta-analysis publication from 2003 found. So in this study, they set out and did a proper evidence-based review, and they concluded and they excluded studies that had no active control group, so no studies that had no parachute. And the outcome was death or major trauma defined as an injury severity score more than 15. And they concluded that they were unable to identify any randomized controlled trials of parachute intervention. Nothing was controlled. So they conclude, as with many interventions intended to prevent ill health, the effectiveness of parachutes has not been subjected to rigorous evaluation by using randomized controlled trials. Advocates of evidence-based medicine have criticized the adoption of interventions evaluated by using only observational data. They conclude, we think that everyone might benefit if the most radical protagonists of evidence-based medicine organized and participated in themselves a double-blind, randomized, placebo-controlled crossover trial of the parachute. So this was part of a sort of comic thing that they do in BMJ in December, apparently. So then there was a follow-up of this where some people answered the challenge and tried to do an actual randomized controlled clinical trial of parachute use to prevent death and major trauma when jumping from aircraft. You can see they call themselves the parachute investigators. And this was a strong group, some various famous institutions. So they conducted a randomized clinical trial about jumping from private or commercial aircraft between specified dates. They tried to recruit 92 passengers, 18 or over, and only 23 agreed to be enrolled and were randomized. And so then they jumped from the aircraft with either airplane or an empty backpack, which was an unblinded study. And they had the same outcome of death or major traumatic injury upon impact. And they found that parachute use did not significantly reduce death or major injury because there were no deaths or injuries in either group. The finding was consistent across all the different subgroups. They did, however, notice that compared with individuals screened but not enrolled, participants included in the study were jumping from a significantly lower aircraft, a mean of 0.6 meters compared to 9,146 meters for non-participants. And also the planes were going at lower velocity for those who agreed to participate, a mean of 0 kilometers per hour compared to 800 kilometers per hour. So they concluded that parachute use did not reduce death or major traumatic injury when jumping from aircraft in the first randomized evaluation of this intervention. However, the trial was only able to enroll participants on small stationary aircraft on the ground, suggesting that extrapolation to high altitude jumps should be cautious. They also noted that when beliefs regarding the effectiveness of an intervention exist in the community, randomized trials might selectively enroll individuals with a lower perceived likelihood of benefit, thus diminishing the applicability of the results to clinical practice. So in conclusion, these are both mock studies, but they're limited because of flaws in design of the trial and limited data. Because in fact, you can't enroll patients to jump out of an airplane at a high altitude. And so we could conclude from our hardcore evidence-based medicine approach that parachute use was widely adopted without any evidence, and maybe was actually encouraged by the limited evidence available in the literature. But once it became adopted, cohort studies became an available methodology after widespread adoption. And you can see that one found a really low rate of like about a half fatality per 100,000 jumps. And that was consistent over many years in the United States. But data consumers should be aware that a biased party posted these results, the U.S. Parachute Association, that the denominator of the incidence rate was estimated and that the results were not peer-reviewed. And so we have only flawed level 2A evidence regarding the value of parachutes for gravitational challenge. So these anecdotes demonstrate that levels of evidence can be misleading for issues that are not best addressed by clinical trials. It's more important that the most valid possible design be used rather than that a study be a randomized controlled trial. However, for treatment, usually the best design is a randomized controlled trial as long as one can be done. And journals and evidence-based reviews should bear in mind the importance of the question and the validity of the study design rather than automatically discounting non-randomized controlled trials. So looking into clinical epidemiology, which I'll spend the rest of the talk on, there are various methodologies of which this is just a selection, but burden of disease would typically be addressed with a population-based cross-sectional survey, risk factor identification and treatment safety with cohort studies and case control studies, and survey studies could be done, which is less useful because you only have cross-sectional information. Agreement studies can be done with agreement statistics and kappa calculations. Diagnostic test assessments can be done with sensitivity, specificity, etc., calculations and the use of Bayes' theorem. Treatment effect should be studied by clinical trials, but could be done with simulations or with a lot of interpretation from a cohort study. We did that early on in the site study when trials weren't really available. Treatment safety I addressed, and then evidence synthesis could be an evidence-based review and meta-analysis, which could be applied beyond trials. So some examples of these that I've been involved in have been the Aravind Comprehensive Eye Study to estimate the burden of uveitis in, at least in Tamil Nadu. The site cohort study has many risk factor-oriented papers looking at sort of secondary outcomes and calculating risk factors. I'll just give examples of that. We did an agreement study, which surprisingly was the first one to look at whether we grade cells and vitreous haze and managing uveitis in a fashion that agrees with each other. Diagnostic test assessment, I didn't have any until one of Rupesh's studies I was participating in published last month. And then treatment effect, I have examples from the MUST trial, point and merit, treatment safety from the site's primary results, which I presented the last time I talked at Proton, and then evidence synthesis and evidence-based review in cataract surgery, and many others that Rupesh has done that I am a co-author of. So in summary, then, randomized controlled trials are generally the best for assessing treatment efficacy if they can be conducted ethically and practically. And so the parachute thing is a humorous example of that. Evidence synthesis of trials provides optimal evidence if enough valid trials are available, but it leaves open the question of how many you do once you have a clear result. And some err by only including trials or giving more weight to a trivial-sized randomized trial than a sufficiently powerful, well-designed cohort study. But we should remember that most issues of interest cannot be addressed by trials, and studies of those issues should not be ignored or discounted. And reliable evidence can be generated if the optimal method is used, even if it's not a trial. And a good example of this is synthesis from non-trial methods with, say, the Global Burden of Disease study, which is the studies that perhaps has the highest impact available. So let me just go through some examples for the rest of the talk. So looking at population-based cross-sectional survey with the Aravind Comprehensive Eye Study. So a population survey estimates the prevalence or burden of disease and can do a cross-sectional risk factor analysis. Some of the famous eye studies include the Beaver Dam Eye Study, the Baltimore Eye Survey, and the Rapid Assessment of Avoidable Blindness method, which is the major contributor to the vision loss expert group evidence-based reviews that are reported with the Global Burden of Disease study. It's important that these be population representative studies. So like if you just go looking around your tertiary uveitis clinic, you're not going to get a very representative sample for the population. And a population representative sample is one in which everyone has a known chance of being selected to avoid selection bias. Usually we use census data and randomly select administrative units and then enroll all persons within those units. And we perform some kind of questionnaire and possible subject examination using repeatable methods to diagnose the issues of interest. So the National Health and Nutrition Examination Survey is a commonly used study for this kind of thing in the Beaver Dam Eye Survey or study. If you do serial surveys like Beaver Dam, you can convert the population sample into a longitudinal cohort study where incidence can be measured. But if you're only observing infrequently, you can't use survival analysis, which would be the usual way for a prospective study. So some of these have been done in uveitis. And so there have actually been two sort of full-fledged population-based prevalence surveys done both in southern India associated with LV Prasad and Aravind. And most of the available evidence besides those comes from a limited number of studies that have used sort of natural populations like healthcare maintenance organizations such as Nisha and Eric Suler and others have done. And these are some of the PubMed IDs of some of those studies. And this is looking at the vision loss, which was only done in the Andhra Pradesh study associated with LV Prasad. And so about 270 per 100,000 or 0.27% had reduced visual acuity in the general population and 0.16 worse than 660. So if you project that out, then you have something like 20 million people in the world that have visual impairment due to uveitis and about 12 million with the US definition of legal blindness. So this is the study I was involved in. This is something we did sort of post facto after this Aravind Comprehensive Eye Survey was done. And the goal was to better characterize the risk of uveitis in the general population and of vision loss. And the parent study was already complete. It had been a two-level cluster sampling study in a population representative sample of about 5,000 people ages 40 and older, the common age, often it's even 50 or older, in 3 districts in Tamil Nadu. And it included a comprehensive eye examination by an ophthalmologist who recorded diagnostic codes and also data about specific fields, including posterior synechia and cells. So that was what enabled us to determine if a subject had uveitis. If they did, according to that, then we reviewed the charts, which were still available, and Rothinam and I reviewed them to see if they were a real case of uveitis to confirm the cases. And then we calculated the prevalence based on the number of cases per population with confidence intervals. And so we saw that most uveitis in this area was endogenous, although a significant amount was things like post-cataract and trauma and so on. It was actually more common in males, which is not the typical observation in this population. So that probably was by chance, although it looks like we have a statistically significant difference here. And it tended to be more with age, which you have seen in some of the sort of larger scale or sort of Western studies that have been done, like from Kaiser. And most of them were posterior uveitis cases in this area. So probably these were toxoplasmosis or tuberculosis cases, although it wasn't clear from the sort of limited contact with the patients. And in terms of the ones that had reduced visual acuity, it was almost all with the posterior cases. And so our results suggested 1 in 330 in rural South India have been affected by endogenous uveitis, and that posterior uveitis was associated with poor vision, but others not so much. And thus uveitis is important. And so I think we know that. If we look at all of the population surveys available, at least at the time I did this review a few years back, vision loss is substantial in tertiary referral populations and in the South India general population from both this study and the Andhra Pradesh study, maybe because there's more toxo and tuberculosis than in other places, but it's still important. And although the severity in the general population is doubtless much less, uveitis may be the fifth to seventh leading cause of visual loss in developed country populations, and possibly more in developing countries where people may not be treated and there are more infectious cases. And so the treatment or the impact might be getting less with scale up of treatment globally, which we should all be involved in doing. And it has a higher impact per case than age-related eye diseases. So if you were to look at years of vision loss, it would be relatively higher than fifth to seventh potentially. We know from the MUST trial and the site cohort study that patients under treatment can do well over time here with doing equally well by 7 years as at baseline, and here showing improvement over 5 years for most of the cases except posterior, where maybe there was choroidal neovascularization more often, where it was sort of back to baseline at 5 years. All right, moving on to cohort studies and case control studies. I'm going to do this out of my order just for convenience. So if we're trying to look at safety, we need to realize that adverse events are uncommon to rare. And so a very large amount of experience is required to see if treatment increases risk or not. And so usually an investigation like this is provoked by a cluster of adverse events. And it's usually almost impossible to find this out from a drug approval trial, because usually it can only be several hundred people followed in the trial. And I'm going to try to turn this phone off because the immigration person is trying to reach me while I'm talking. So it's usually impossible to do it because of inadequate sample size in a trial. Even with long-term extensions of trials, the samples are still small. So a large cohort study is ideal. If you ever look at the site design paper, we sort of go through all of this. And so I'll give as example the site cohort study, but very briefly since I presented it before. The key features of a cohort study are a defined group of people, a population that's followed over time for an outcome, and potential risk factors are measured in advance of the outcome. It can be prospective or retrospective, and population representative or not. It can be an intentionally created cohort like the site cohort study, or a big data database like insurance database such as Optum. And unless follow-up is very close to complete or very infrequent, survival analysis will be the backbone of statistical analysis. Okay. So the problem for the site study was that immunosuppressive therapy is an important thing for eye disease and has a key role in preventing blindness. But patients and doctors often are concerned about long-term risks such as cancer. So we wanted to sort of settle that issue. And as we discussed, we did this large study with about 18,000 patients, and we found that in terms of all-cause mortality, it wasn't increased with TNF inhibitors, tending to be a little more with etanercept, which may or may not be real, and neither increased with antimetabolites or cyclosporin. And then tacrolimus tended to be a little higher, but it's very wide confidence interval, so not much confidence in that. And then alkylating agents tended to be a little higher. This is looking at, with the squares, those excluding systemic disease, so the ideal cohort, because people with systemic disease might die of the systemic disease, and then all patients with the round ones, but the patterns are similar, but tend to be worse, say here, and in the pure group, it's better. If we look at cancer mortality, we have similar results. And if we look at overall cancer, again, we have similar results, except it's a little more pronounced in a favorable way that actually adalimumab in the all-patient group was barely statistically significantly better than unexposed patients. And likewise with methotrexate, and antimetabolites as a class were nearly statistically significantly better. So I don't think we should take from that these are protective against cancer and that we should all be going out to our health food store and buying antimetabolites or adalimumab to take to prevent getting cancer. But I think we can be pretty confident that these are not increasing the risk of cancer. Probably more information would be valuable about etanercept and tacrolimus, but you can see with the tanacercept, it's completely different in the two groups, so probably this is just due to some sort of limited sample size. Alkylating agents tend to be a little bit higher, and I still worry about them, but we weren't able to prove they increase the risk of cancer. And in fact, increase the risk of cancer. And in fact, chlorambucil that I didn't show in the publication actually didn't have any cases, but it did have cases of death from cancer, and the mortality study could go further back than the cancer study because the cancer registries were not online as quickly. All right, so we can use data from the site study to look at all kinds of things, and predictive factors are a lot of what epidemiology is about. And so a study trying to identify predictive factors from some relevant clinical outcome are patient or treatment characteristics can be associated with better or worse outcome. The outcome should be something relevant like mortality, blindness, choroidal neovascularization, cataract, etc. We have a long list that we looked at in site. And the predictive factor hopefully would be modifiable, but if it's not modifiable, we could still counsel patients about it. So some examples would be Beaver Dam Eye Study, that was a serial survey where they looked, say, at cigarettes and macular degeneration. Case control studies, like within the age-related eye diseases study with dietary lipid and macular degeneration. And in the cohort study, we look at remission or the occurrence of adverse outcomes of uveitis and predictive factors. So let's just go through cataract just to talk about this in more detail. It's a leading cause of reversible visual impairment in the uveitis population, and accommodation is lost forever in this younger population. It does have relatively good outcomes with surgery, but not perfect. And I would like to argue that prevention of cataract is something we should think about at every visit of our uveitis patients. So this is a study we did looking at the incidence of and risk factors for cataract in anterior uveitis cohort. And this was a big cohort, over 9,000 eyes of over 4,500 patients with anterior uveitis. And it was mostly recurrent and chronic uveitis because it's from tertiary centers, but we had some primary cases too. And we had 770 cataracts, so about, I guess that's 1/7, ended up getting a cataract. And this is looking at the incidence over time with a confidence interval. And so you can see you get out even to 17 years and it's not half have had cataract yet. So it's not inevitable in our uveitis patients. And if we look at risk factors, age, as we would expect, is a risk factor, especially when we get to be 65 and older. This is kind of discouraging for me, although I don't have cataracts yet, thankfully. And then anterior chamber cells are a risk factor with a dose-response relationship. So the more cells you have at the previous visit, the higher the chance of having a cataract causing a visual acuity of worse than 20/40 at the next visit. The chronic anterior uveitis had a higher risk of cataract than either recurrent or primary, and recurrent was statistically better, although primary looks like it's actually less, but as I said, we had fewer cases, so our confidence interval is wider. Band keratopathy, posterior synechia especially, it's a big hazard ratio, and IOP spikes are all associated with a substantially higher risk of cataract. And so are use of topical steroids, especially it seemed like in our study there was an inflection point after adjusting for other factors around double the risk at 2 drops a day. So that's less than what you often hear about with the JIA patients from Hopkins. And so I would recommend trying to get to 1 drop or preferably 1 drop every other day because this was almost significant. And then periocular and systemic corticosteroids we couldn't prove were associated with increased risk, but they look like they're associated with risk. These aren't used that often for anterior uveitis. So we made this risk point scale, which you can look at the paper to get. And basically, the more points you have, the higher your chance of cataract. And so you can see if you have almost no points, you can be out to 20 years and have 70% chance of still having your lens. And then a medium amount if you have 3 or 4 points. And being 65 by itself would be 4 points. And if you have 5 points, so that might be having posterior synechia and taking some eye drops, then you have a higher risk. So there's a high risk of it. So prevention of cataract then is an important goal, and we could reduce the risk in our chronic anterior uveitis cases by minimizing risk points, especially to quiet the uveitis. Use 1 drop a day of predacetate or equivalent or less, preferably less, and possibly a safe dose of oral corticosteroid might have a better risk profile. We'll see from MUST that it is relatively safe at low doses, and prevent sequelae as much as possible. And if we could cause the uveitis to remit, or if it's a recurrent or primary acute anterior uveitis remitting case, the risk will be less. I'm going to mostly talk, except for MUST, just showing the abstract. And so remission of chronic anterior uveitis was something that we looked at because we wanted to estimate the incidence of remission and using the SUN definition. Although if the patient had all visits until the last visit quiet off treatment and it was less than 3 months, we counted that too in our primary analysis because often those patients don't come back anymore. And so we looked at 2,795 eyes of 1,600 or so patients with about 8,000 eye years of time, and only about a third were in remission by 5 years. And predictive factors, they were all kind of risk factors pretty much, were having bilateral uveitis, having a longer duration of uveitis, having prior cataract surgery and glaucoma surgery, which might be severity factors, and in time-updated analyses, having keratoc precipitates and synechia, so that, again, it might be severity factors, were predictive of not going into remission. Systemic diagnosis with JIA and spondyloarthropathy also were associated with reduced remission incidence over time. So that's kind of interesting because we think of spondyloarthropathy typically as a remitting kind of condition. Older age was associated with a higher incidence of remission, so that was the only one that looked favorable. So we should think then, if we're deciding to stop our suppressive treatment for these patients, that it's not too likely they're going to be in remission. It doesn't mean we don't try, but we need to be prepared and watch carefully because they likely will relapse. And this is showing the incidence of remission out to 10 years, so it's not even 50% by 10 years. All right, so a case control study is the next method. With a case control study, we start with the diagnosis. So cases of a condition of interest and appropriate controls. And the appropriateness of the controls is the hardest aspect of the study that's most likely to mess up the study. And it could be matched based on important factors like age. You might do random selection from a sampling frame, like if you're doing a case control study and a cohort study that you often would do if you had specimens, but you don't want to use all the specimens in the cohort. And often there will be more controls available than cases, and if you can have up to 4 to 1, it helps you a lot with your statistical power, but you don't gain much after that. Another key limitation is that you have to look back before the occurrence of the disease to look for the factor, and this could be subject to recall bias. So that's a key limitation of this method. And then you do regression using usually logistic regression of the predictive factors against case control status. So this can be quite nice if you have a fixed aspect like sex or like genetic factors. So we looked, this was really Lucia's leadership, to look at low vitamin D levels and the risk of incident uveitis. And basically we found that those with a low that with hypovitaminosis D, we said of, I think it's 20 or less, 20 nanograms per milliliter or less, had about a 20% higher risk of developing uveitis. Okay, so let me get on to the MUST trial that some of you will be interested in. So a randomized controlled clinical trial is a cohort study, and the only difference is that one or sometimes more than one covariates values are randomized. So that'll usually be treatment. But if you could potentially randomize two, like maybe 2 treatments with a so-called factorial design, it's always going to be prospective, and the analysis is going to be like a cohort study because it is a cohort study. It has, however, enormous regulatory and ethical burdens to assure the safety of subjects, and so it's a huge time and financial investment. It's useful for disease treatment and potentially for prevention treatment, which requires much larger sample size and is harder to pull off. So it's made the highest level of evidence based on only 2 positive design features. One is that the randomization avoids indication for treatment bias, so it means the severity will be balanced in the two groups, at least if it's a respectable sample size. And also, there could be confounders, that is, covariates that cause the diagnosis that might be distributed unevenly among the two treatments. So if it's randomized, whether that confounders are known or unknown, it'll tend to be balanced. So those are really the only two reasons a clinical trial is better. You can also implement masking, which could be an advantage to avoid participant or assessor reported data like patient reported outcome measures being biased by presuppositions of the people reporting. And the regulatory bodies typically require two of these to approve a drug for use. And so here's some examples of studies in uveitis. And I think I'm going to go ahead since it's taking a long time. So let me talk about the MUST trial. I'm going to give more slides on this because it's probably important. So acknowledging the sort of steering committee, or not steering committee, the executive committee leaders of this study. And this was to look at whether the fluocinolone acetonide implant was superior. It was we hypothesized it would be superior to systemic sort of rheumatological treatment. And if superior, would it have a role as initial therapy? So we thought, ophthalmologists or surgeons, we're treating like a rheumatologist. People are going to like treating with implants, and we want to sort of see if it's really better before everyone starts using it. This was a 23-center randomized clinical trial and then an extension of follow-up after 2 to 5 years of follow-up as a trial with one-to-one randomization by patient so that we could look at patient-reported outcome measures, which you can't do by eye. And it was stratified by whether it was intermediate or posterior panuveitis. So we didn't look at anterior uveitis, which the implant would not be appropriate for. We followed up at least semi-annually and more often earlier. And these were the eligibility criteria, basically people for which one of the treatments would be indicated. We tried to be liberal about, we wanted active uveitis, but we had trouble recruiting. So we said active uveitis within the last 60 days, and they had to have at least some vision and not have really high eye pressure. So basically it had to be indicated and safe. We didn't want an optic nerve that was going to snuff if there was a pressure spike. So the implant, I think you're familiar with how it's put in, and the systemic therapy, I think you're familiar with as well, which we followed the guidelines paper from 2000, basically. So 255 patients with 479 uveitic eyes were randomized, and the eyes were treated with implant if allocated to implant, or the patient treated with systemic therapy if allocated to systemic therapy. So if there are two eyes, it would be two implants. And we had pretty low loss to follow-up by the 2-year time point with more than 90% still under follow-up. Then we got an extension to follow up for 5 more years to get 7-year follow-up. And we had 70% still under follow-up by that time, so not as good, but the characteristics were largely the same with no statistically significant differences in any of the baseline covariates. And the results showed, are best understood if we sort of start with activity. Visual acuity was actually the primary outcome, but we can see that activity over time improved with treatment, and it improved more with implants. But when you get out to 5 years, then there started to be a lot of reactivations in the implant group, and then the two were superimposed. And so the implant was better for the first 54 months. And visual acuity also was about the same in the two groups through 54 months, but began to get worse in the implant group after that. And you can see the box plots show like this would be the 75th percentile, or I mean the 95th percentile of the distribution down here. This would be the 75th. And so you see that the tail of the distribution is getting worse in the implant group. And so we did get to a point where there were statistically significant visual acuity differences of about 7 lines between the two groups. I guess it was a little bit more at the, or no, it was about, 7 lines difference from baseline by 7 years. So if you look at this, it's not really that big of a difference. Like both these groups did much better than I expected at the beginning of the study for 7 years follow-up. If you look at local side effects, it was expected they would be more with the implant, and indeed they were much more. And even getting glaucoma in a clinical trial where you have a coordinator chasing you was 3 times as likely in the implant group. And this was because the patients were so happy that they didn't have to worry anymore about their uveitis, that they didn't worry enough and didn't come for follow-up as much. And so then they came back cupped out in a number of cases. So that's a lot of glaucoma cases. And this was optic nerve damage shown by optic nerve stereophotos and visual fields, taking into account sort of baseline effects in the visual field, because posterior uveitis can affect the visual field too. And really a high rate of glaucoma surgery in the first 2 years, and still significantly higher for 7 years out. In contrast, the systemic complications weren't statistically different between the groups. They did tend to be a little more with the systemic group, and probably if we aggregated this, it would be significant, barely. And if we look at immunosuppressive therapy complications, we don't see any signal. The biggest difference showed a higher risk in the implant group, which was not close to being significant, and I'm sure was due to chance. We did, however, see that there were more infections requiring antibiotics in the systemic group, but this was unmasked. And I would argue that if you have a fever and a cough and you go to your primary care doctor, they will probably not treat you until you tell them that you're taking corticosteroids and immunosuppression, and then they probably will. So that might be all this is, but maybe it could be a difference. If you look at hospitalization for infection, it was actually slightly more in the implant group and was almost zero in both groups. And even weight gain didn't differ between the two groups. So we conclude this has some limitations. I'm going to skip over them for now. But the better visual acuity and less local side effects without increased systemic side effects supported systemic therapy as first-line use, and also because it's cheaper. But we should remember the implants outcomes were good, and for the ones where the systemic therapy fails, which isn't very many, but it's some, that this was a good treatment. Unfortunately, this is being withdrawn from the market soon. And it was remarkable what a good safety profile there was for the systemic approach. And it was also remarkable that the implanted eyes remained quiet longer than was expected. So it was about 4.5 to 5 years to reach half relapsing, and 45% never relapsed in 7 to 10 years. And so the implant really was better than people thought. So it provided a lot of opportunities to do like a cohort analysis and look at other outcomes. And so there were 26 publications, maybe one or two more by now. And it has the second most AUS best papers of the year after Sight. We have about 50 publications from Sight. And so they're kind of complementary. The Must has way more information about patients, but much, much less person time and much, much more expensive to do. All right, so moving a little more quickly now. Agreement studies are to look at agreement between two observers where neither is the gold standard. And statistics include simple agreement and a kappa statistic, which shows you agreement beyond what would be expected by chance. And so I'll give you an example from one of our studies. And interclass correlation coefficients can be used for continuous variables. So the grading of vitreous haze for the Miami photographic approach to grading vitreous haze did that in their study. So here is a study, the easiest study I ever did, which was completed in 3.5 days, plus the analysis, 1 day with Suda, 1 day with Virander, and 1.5 days with Rothinam. And we just looked at uveitis patients they had collected one after the other with the same equipment. I think we may have not been perfect in that at Shankar Nethralaya, and then we just compared our outcomes. And so we can see in terms of the location of uveitis, according to the sun phenomenon or the sun approach, including the anterior and intermediate uveitis, we weren't really having that much agreement. We had sort of moderate kappa with that. If we got rid of the anterior and intermediate uveitis and just called it intermediate, it was somewhat better. But this means that we might not be perfect in the patients we enroll in trials. If we look at exact agreement on findings of anterior chamber cells, it was only low to moderate, and gradings of flare a little better, and vitreous cells, a little better, and vitreous haze likewise. But if we look at agreement within one grade, it's really good. And so this led the FDA to kind of accept this as an outcome for trials, although for various reasons, the field doesn't love this outcome very much. And so this then kind of established that anterior chamber cells and vitreous haze could be used in clinical trials, and it would be reasonably reproducible if we do within one grade. We counted 0 and 0.5 plus and 1 plus as separate ordinal grades in our analysis, but the FDA has interpreted 0.5 plus as half a grade and considers going from 1 to 0 as only a one-step improvement. So that didn't work out quite the way we would have liked. We should have called this like A, B, C, D. There was also this interesting study from MUST where we did clinical examination, fundus photos, fluorescein, and OCT on all the patients at baseline. And we found that OCT was the most likely to return usable information, and that the agreement between macular thickness by OCT and macular leakage by fluorescein are actually not that good. And this, I didn't realize this, I just wanted to prevent it because this was a big realization for me. Because macular leakage probably causes macular thickness, but this is a physiologic problem, whereas the thickness is an anatomic problem. And so they're not exactly the same thing. And some cases, like especially young, healthy eyes, might have macular leakage without thickening, and old, sick eyes might have thickening without leakage. And also, this can resolve before this does. And so the point of this was basically that the agreement was imperfect, and that we might use OCT as we're all doing now, because it's cheaper and it has a greater probability of providing useful information. But we might consider doing fluorescein if macular leakage would, in addition to that, in addition to OCT, if it would affect our management. Okay, sensitivity and specificity, positive and negative predictive values, and likelihood ratios under Bayes' theorem. This is the paradigm for testing and classifying things accurately. And so we start with sort of a certain certainty that we have of say, a diagnosis, and then we collect data, and the data tests, like lab tests, will have a certain sensitivity and specificity, which are intrinsic attributes of the test. And then the positive and negative predictive value will depend on the pretest probability. So like if you test random general ophthalmology patients for syphilis and have a positive result, that would be different than if you test uveitis patients for syphilis and have a positive result. And this kind of test requires a gold standard, which has a lot of challenges in uveitis. And so Rupesh has been very active in trying to work this out. And Rupesh's group with William as the first author just last month presented this. So my first sensitivity specificity study, in this case just as a co-author, and they looked at 3 different AI methods for trying to determine if, we looked at that, trying to determine if uveitis would relapse or not, and they found that we found this random forest model was a little bit better, but none of them really had great sensitivity and specificity, and so we still need to do better in that regard. So lastly, evidence synthesis would, in theory, be your highest level of analysis if you have multiple trials on the same issue, which we don't really have in uveitis. This is a very standardized method developed by the Cochrane Group and others, and they call for a published protocol and methods that don't involve judgment but are scientific. And
Yes, lot of epidemiological studies have been done from South India, North, and also the East zone. And the commonest was the anterior. And depending upon that, as the etiology wise, the infectious etiology is the commonest from India.
That's nice. And which infection you managed to get in your study? Which was the infection which was common?
Tuberculosis.
Okay. Okay. So does Uveitis Society of India or you people have a registry which you people collect data together?
Planning to start.
That's very good. That's fantastic. Very good. Okay. Good. Any other comments or any queries from any other colleagues?
Hi, Prof. Oh, sorry, Prof, you're muted.
I guess I forgot that the power can still go out and turn off my wonderful new server. So anyway, I was going to show an evidence-based review that we showed about 70% chance of getting 20/40 or better with cataract surgery with phaco and extra cap, and also that using acrylic lenses was better than silicones. So I'll just leave it at that. Does anyone have any questions? for me? Nobody? Can you hear me?
Yes, we can hear you.
Okay. All right. Well, anyway, hopefully you could hear me up to the point where the power dropped. Um, anyway, hopefully this is helpful and some understanding. One of the sort of things that I thankfully realized early in my career is that the best possible epidemiological design for your career is a cohort study, because you can look at all kinds of different outcomes and all kinds of different predictors. And so this is why SITE, has so many papers compared to other studies that we did, like the agreement study pretty much just has one paper. We repeated it with sort of the new Miami system for grading haze, but the sort of cohort study is the one that really gives you a lot of output. So, and then evidence-based review is popular, as those of you in the proton group know well. So. So anyway, congratulations to everyone in Singapore on this wonderful initiative, and thanks for inviting me.
Thank you for your time. If there's no other questions, we will end the Zoom live in about 30 seconds.
Yeah, so there was a text or chat that the paper from Hopkins showed 3 drops a day or less was safe regarding cataract. So our study from SITE had a sort of a lot more data from that. Actually, it would have included those patients for the most part because they were from Hopkins, which was one of the SITE centers. But it's possible that that was either a type 1 error compared to that, or maybe that the children, that was a juvenile idiopathic arthritis cohort. So maybe the children's lenses are more resistant than adults. But the data from the SITE cataract paper, something like 10 times or 20 times as many data. So it should be more valuable, I think, for that. And, since getting a cataract in a child is so bad, I wouldn't want to take chances. Having active uveitis is bad too, but, this is why we go to immunosuppression early in children. So I think there's one more chat question. Oh, just saying thanks.
Yeah.
Okay. Well, thank you all. And sorry for the interruption at the end.
Thank you, Prof.
Okay. Take care.
Thank you, everyone.
All right. Bye-bye.
Thank you, Prof. Bye, everyone. Thank you.